Okay, good morning, everyone. Welcome to Wednesday morning rounds. It's my pleasure today to have a couple guests from TOH. Dr. Lisa Bromly is an assistant professor in the Faculty of Medicine at the University of Ottawa, and she's the medical director of the Ottawa Hospital Substance Use Program. She works in both the inpatient and outpatient community settings and provides addiction medicine consultation services for inpatients to TOH and UOHI, and works in the low barrier opioid agonist treatment in the RAM clinic at the Sandy Hill Community Health Clinic in Ottawa. And she's been a methadone prescriber since 2001. Tali Cahill is an advanced practice nurse and the program manager of the substance use program at the Ottawa Hospital. And she is on the board of the Harm Reduction Nurses Association and the Canadian Nurses in HIV and AIDS Care, and has worked in harm reduction since 2017. So I asked the team to come and present today because it's an issue for our patients, and we've certainly seen an increasing number of patients with substance use issues over the past 4 or 5 years. So thank you so much for joining us today, and we look forward to your presentation.
Yeah. Thank you so much for that introduction, and thank you for inviting us. So the way this is going to work, I have slides that is going to take probably about half an hour, and then Tali is going to sort of jump in and we're going to talk about a case. Oh, minimize. Oh, yeah. Yes, thank you. Good. All right. And so in terms of disclosures, I do have some commercial interest to disclose that I have received honoraria for Medicom Advisory Board and for Master Clinician Alliance for development of mentoring for healthcare providers on OUD. Tali, do you have any disclosures?
I do not.
Okay. Okay. Tali has no disclosures. we both get paid by TOH. Okay. So what we'd like to do in the next hour is just talk about us, introducing ourselves and explaining, well, nobody knows what addiction medicine consultation is. So what can you expect from addiction medicine consultation? I'm going to talk about the two most common substances that we see, alcohol and opioids. So alcohol is hiding in plain sight in front of all of us. So I'm going to talk about the burden of alcohol use. I'm going to talk about the treatment, the impact and treatment of opioid use disorder. We're going to talk about cardiac surgery and infective endocarditis guidelines, and hopefully there'll be lots of questions. All right, whoops, so now okay, so here's some quiz questions. Now I escape, I do this, and I'm working on having a growth mindset. So those of you who are technically talented, you're not allowed to laugh at me. Okay, this is the one. Launch the poll, launch instant poll. Okay. Oh, leave. Oh, stop sharing. Okay, so all of you on Teams, you can go to the poll. Okay, and where are we? I'd like to start with the first question.
It's already launched.
Okay,
Yeah.
Super. So what is the number needed to treat for oral naltrexone to return to heavy drinking? Oh, submit.
It's lots of different.
Okay. Okay, that's the last question. Well, if that's the one that's up, that's the last question. Substance use disorders respond well to treatment with pharmacotherapy and or psychosocial interventions. True or false? And I'm going to just give you a few seconds. Okay, time's up. We're going to do the number needed to treat for naltrexone. What do you think is the NNT for naltrexone for a clinically significant outcome?
Results.
Oh, view results. Oh, looky loo. Okay. Ooh, some of you have been to my rounds before. All right. So how about the next one? Close that. How about the question is, in 2017 and 18, which of the following was responsible for more hospitalizations in Canada? Injuries and illnesses caused entirely by alcohol and drugs, or heart attack and strokes combined? So we're going to view results. Which do you think more?
A little bit of a leading question.
Yeah, well, it's to get you to
No,
think, right?
yeah.
This is not on the exam.
Yeah.
Okay, so some people vote for heart because how could it be? You know, really? So okay, next. Okay, time's up. The next question. In 2019, globally, which risk factor was more highly associated with death and disability? Was it high cholesterol or was it alcohol use? And let's see who thinks. Okay, all right. You guys are wise. You're wise to my tricks. Okay, so is this the last one? Oh no, second to last. Hospitalization is an independent risk factor for opioid overdose mortality in the 2 weeks following discharge. True or false? Only one response so far. Okay. Anyone else? All right. And lastly, the question is, what is the risk reduction for all-cause mortality in people with opioid use disorder while taking opioid agonist treatment compared to no opioid agonist treatment in BC between January 1996 and September 2018, so before the pandemic? What was the risk reduction? So there was no reduction in mortality with taking OAT. There was a 24% reduction in mortality with OIT, 47% reduced risk, or 83% reduced risk. Let's see what people think about that. Okay, how many responses? 10 responses. Okay. So no one chose that it did not reduce mortality. I'm glad about that. And that, I believe, is the last question. I did the very last one. Yeah?
What's the answer to that?
I will get to that.
Oh, you're
That's
gonna
again, I'm going to tease
Okay.
you. Okay, all right. So that's the end of the poll. Let's get back. So I'm going to leave here. Oh,
Okay.
no, no, don't leave the meeting. Okay, don't touch it, Lisa. Don't click on things. Just for me.
That's yours now.
Okay, thanks. So, all right. The NNT for naltrexone, I saw a lot of answers that said 12. And so that was what a meta-analysis in 2014 found. And so the reason I talk about that is like, what is the NNT for, statins or other interventions that you guys all do in cardiology? I mean, I think 12 is actually pretty good for a clinically significant outcome. And, we're not talking about complete abstinence, but for someone who is using alcohol in a harmful way, if naltrexone is able to get them down sort of into less harmful alcohol use, that can actually make a big difference clinically and mentally and psychosocially for that person. There's the reference for those of you who are interested. So in 2017-18, what caused more hospitalizations? Well, no surprise about, since what the topic is, injuries and illnesses caused entirely by alcohol and drugs were more hospitalizations than heart attacks and strokes combined. So we have a 5-story heart institute here in Ottawa, and we do not have a 5-story alcohol and drug institute in Ottawa yet. There's the reference from Cahill. Yeah, 400 per day in Canada. So globally, high cholesterol alcohol. Trick question. It depends on your age. So so for 25 to 49, and I apologize for the super tiny font on here. But for people 25 to 49 years old, alcohol use is a #1 risk factor for loss of disability adjusted life years. Wow, much more than smoking. So if you're over 50, then yes, high cholesterol is ranks one up from alcohol use. I just think that's interesting. We talk a lot about cholesterol reduction, but for folks under 50 that you see, it's probably more important that you talk to them about their alcohol use than put them on than talk to them about their, well, you need to talk about both, but don't forget the alcohol. There's your reference. Independent risk factor for opioid overdose mortality. Yes, that is true. So people who are hospitalized, who have opioid use disorder, are more likely to die of an overdose, of opioid overdose in the 2 weeks after hospitalization. So there's the reference. Now, so the method had a weakness in that, well, maybe the hospitalizations coincided with a period of increased drug use, which led to the circumstances leading to hospitalization. But I think the point of this study is it's important to bear in mind that discharge from hospital is a super, super risky time, and it is something that we should be paying attention to when we discharge someone with opioid use disorder who's using opioids illicitly from hospital, that is a very risky time for them. Okay, so Tali, you were wondering what the answer is.
I don't actually.
Yeah, so the answer is almost 50%. So being on OAT before 2018, compared to if you're someone with opioid use disorder in BC, being on OAT medications reduced your risk of mortality by almost half. So half the amount of mortality. Now, what kind of intervention can we do in medicine that reduces mortality risk like by half, right? That is, to me, that's incredible. And actually, does anyone know what happened after 2018? That was the start of the fentanyl, when fentanyl came into the picture. And guess what? The protection from OAT is even stronger in the fentanyl era than before the fentanyl era.
I think it's important to point out that this is if people, even if people continue to use. So
Mm.
it's not, this is not saying that people were abstinent because of OAT, but that it provided a protective factor even if people were continuing to use drugs.
Like she said. Thank you. There's your reference. And yes, substance use disorders do respond well to treatment. That's why we do what we do, because people get better. And I think often I encounter this therapeutic nihilism, that there's a lot of frustration in caring for people who use alcohol and drugs, but actually, like, the bright parts of my day are to see them get better. So
we don't see them come back if they get better. So
right?
that's why we keep on, it's like this confirmation bias of people just, we see the same people and they come back, but people who, reduce their use or use more safely don't come back to the hospital. So we don't see them, and so we don't see that it works. Yeah.
And in the community, right? So I see that it works when they come back and see me in the community a year or two later. I have people that were here in the hardest to, like 4 or 5 years ago. I have a patient who was here 15 years ago who still sees me after a second valve replacement surgery, and she's doing great. So, kids, job, partner, housed, all that. Okay, so that's the end of the quiz. How am I doing? Okay, I'm gonna go for about 20 to 17 minutes. Addiction medicine is a thing. It's a medical subspecialty that has been recognized since 1990. It is a chronic, treatable health condition for which prevention and treatment approaches are generally as successful as for other chronic diseases. So in cardiology, you folks, you manage chronic diseases all the time, and addiction is exactly the same. And it is accredited. So both the Royal College and the College of Family Physicians of Canada give kind of a special, recognition of training in the subspecialty. So it's a thing. Now, again, I apologize for the busyness of the slide, but this is everything we do, right? We do a lot of things. So we will take a history for you. We will clarify how severe, what is going on in terms of the substance use. We know how to take a history from these folks. We are able to model effective communication and anti-stigmatizing language for folks. We know how to do motivational interviewing to kind of clarify what people's goals are and help them move towards their own goals. We know the drugs. We know all about methadone, buprenorphine, and slow release oral morphine. Methadone seems to be intimidating for a lot of people. It's a dangerous drug. We prescribe as physicians and prescribers, we prescribe dangerous drugs all over the place. But our team, we know methadone and we know buprenorphine. We can help you with folks with a super, super high opioid tolerance, right? So folks who use fentanyl have opioid tolerances orders of magnitude higher than folks who are opioid naive. And I think we can help you kind of figure out which bucket does this person kind of fall into. Is this someone who uses a few Tylenol 3s or a few Percocets, or is this person using fentanyl every day and they need gram doses of morphine equivalents to reduce, to prevent pain and withdrawal? We manage alcohol use disorder and start people on meds. And, you know, we're a resource. We, you know, teach people. We will take residents. And we do this. So why should you care about addiction medicine in hospital? So what? Well, as I said, it has a huge impact on hospital use. And it's a great time. It's a wonderful opportunity. People have endocarditis, or they have, you know, overdose, or being treated for that. They might be pretty motivated to make a change. You know, treatment that is initiated at the point of contact with the healthcare system is much more likely to result in retention and treatment than, oh, you go over there to that other place and get your treatment. We don't do that for diabetes. We don't do that for hypertension. If someone's diagnosed with diabetes, we start treatment right away. Substance use disorders should be no different. We are effective. We are cost effective. We reduce readmissions and costs. I think something that is that I don't want to dismiss too much is actually people feel a lot of moral distress. I think providers feel moral distress in caring for these folks because they are complex, they are challenging. You know, people feel kind of that they don't have the skills, and we can help with that and sort of reduce the moral distress of the treating teams. Tali, do you want to expand on
Well, I
that?
think the other thing is just kind of not only moral distress, but people are really uncomfortable with the high doses of opioids. So especially for me as a nurse, like it helps that I can give some kind of education to nurses who may be like worried about the just the doses itself that might be, you know, causing someone, or, you know, assessing sedation. It's something that people aren't taught in nursing school, and it can help manage the patient if they actually get like the opioids that are ordered. Understand people's discomfort, and so we can work through that.
Super. Here's the money shot, right? That admission, readmission free survival, right? So the addiction medicine consultation, it shows that gap, that when addiction medicine consultation is involved, people are readmitted less often. Okay, so what? Great. So Dr. Bromly, fantastic. We agree that addiction medicine is an important thing in hospital. What about specific to cardiology? Well, guess what? You guys are already doing it. You have been doing it for a long time. Do you know what I'm talking about? Anyone? You guys are experts. Smoking cessation. You guys invented it. Like the Ottawa model for smoking cessation. Ta-da! So kudos. So, you know, this should not be too much of a, you know, this should not, hopefully not be too much of a stretch for cardiology. And guess what? Alcohol is a huge risk factor for hypertension. So I hope that you're asking all of your hypertension patients about their alcohol use. Alcohol causes cardiomyopathy, and injection drug use causes endocarditis. So this is why you should be interested in addiction medicine and cardiology. Oh, Dr. Bromley, we're so busy, you know, it's hard to ask about alcohol use. There is one, if you have time for one question to ask about alcohol use, what is one question? I will tell the answer. The question you can ask your patients to screen for unhealthy alcohol use is, in the past year, if you're talking to a female, how many times have you had more than 4 drinks? Or for a male, how many times have you had more than 5 drinks in one day? And a positive answer, positive screen is that has happened at least once in the past year. Is that a diagnosis of alcohol use disorder? Absolutely not. Is that an indicator that you should kind of, if a positive screen, you know, it's a screening question. So if it's positive screen, then you should go on to ask some more questions. And it's beyond the scope of what I have time for today to talk about an easy and more in-depth kind of assessment of alcohol use. I'm going to leave you with some resources at the end that you can go to kind of bring yourself up and sort of how to ask for this quickly, efficiently, and effectively. Okay, so, oh, yeah, okay. So quickly, AUD medications, alcohol use disorder, anti-craving medications are effective and safe. Naltrexone and acamprosate are the two ones with the most evidence. They should be routinely offered to all people who have problematic use of alcohol. And which one to pick depends on the patient profile. The one that should be offered the most is my first choice if they don't have any contraindications is naltrexone. It's easy to take. They don't have to be abstinent before starting. They don't even have to be committed to abstinence. People have a lot of ambivalence. It's a big step. I don't know if I can be abstinent, doctor. That's okay. If you take some naltrexone, alcohol use will just become less interesting to you. And that's truly how it works. Why does an opioid antagonist work for alcohol use? We don't know, but probably because some of the pleasurable effects of alcohol are mediated through the endogenous opioid system. So you block that and alcohol is less reinforcing. So it doesn't give that little charge of pleasure as much. And guess what? You guys already use naltrexone, don't you? Contrave, right, for weight loss. I guess that was sort of before the Ozempic era, but bupropion and naltrexone combination is indicated for weight loss. It's covered for folks on ODB. You have to put the little LU code of 532. Very quickly, acamprosate is a maintenance of abstinence medication. So for people who have become abstinent and wish to remain abstinent, why does a glutamate antagonist promote abstinence? Probably because alcohol use sort of causes relative glutamate overactivity, right? That like the over-excitatory, right? Alcohol interacts with the GABA receptor. And so with all that GABA sort of, all that depressive effect, you get these compensatory mechanisms of more glutamate, more excitatory signaling the CNS. Well, guess what? If the extreme of that is delirium tremens, right? Acute alcohol withdrawal syndrome. But so the glutamate system, like it probably relieves some of that little subacute withdrawal tickle that they have. And so that is the theory. I cannot point you to any, RCT that's the way that it works, but that's the theory. It is excreted only by the kidneys. That is the only way that it gets out of your body. So the person should have more or less intact kidneys if they're going to take this medication. Okay, that's it. I'm going to not going to spend more time on that. So if you don't have time for all of this and you don't know what to do, but you've identified someone who might have a problem, this is your resource. The Royal Ottawa has an excellent RAM clinic, rapid access addiction medicine clinic. People can self-refer. The RAM clinic appreciates if you send a referral, which I believe is now an Epic. There's a referral in
yes, .ram referral.
Okay, so
if you want to do it.
Okay, you know what? Next presentation I'll put that down.
.ram referral. Yeah.
Okay, and so they appreciate a referral because then they can go into Connecting Ontario and that sort of gives them permission to sort of start looking into this case. Patients can self-present it now. The one thing about the Royal is it helps a lot if the person is digitally literate, like if they have a device and Wi-Fi. A lot of our folks don't have that actually. But if they do have a device and they do have internet at home, they just click and they log into the virtual waiting room and they just hang out, play their solitaire while they wait. And the triage person from the RAM clinic will take their call virtually and sort of go from there.
So they can do that while they're in the hospital. If some reason we can't see them, if it's a weekday or something like that. If they want to start something right now, they could just sit while they're in the hospital and wait in the waiting room and get an intake from a nurse that same day.
Exactly. And the RAM also sort of fast tracks their connection with Access MHA, which is the psychosocial, which is the portal for psychosocial interventions in the region. Okay. All right. Let's talk about opioids in 5 minutes or less.
Yeah.
So, if you are not on a desert island for the last 5 years, you know that there's an opioid overdose toxicity crisis out there. And it is only getting worse. The pandemic made it way worse. So this is Ontario. This is from, I didn't put the reference. This is from Public Health Ontario, their interactive opioid risk tool. And so this is Ontario wide. So the blue line, deaths. So you can see it's just completely going up vertically. And if you think you're seeing more of these folks in hospital, yes, you are, right? Hospitalizations are also going up. Opioid toxicity deaths in Ontario, sort of on a quarterly basis. So you can see you can really see the effect of the pandemic there, that the pandemic made it just like so much worse. Canada-wide, so these are data by year for all of Canada. The little line at the end is they haven't completed the assessment of stats for 2023. So that far right-hand bar is only going to go up. So that's just incomplete 2023 data. So
we have 22 deaths in Ottawa for January of this year, which would represent a plateau or increase from the previous year if that trend continues.
So it's not going away. It's not getting better. Endocarditis. If you think you're seeing more endocarditis patients, well, why, yes, you are. I'm not going to go over everything in the slide, but more endocarditis, more spinal infections, no more osteomyelitis, more infections of skin and soft tissue between 2013 and 2019. So yeah, you're seeing more of it. So very quickly, I've talked about the benefit on mortality of opioid agonist treatment medications, which are methadone, buprenorphine, and slow-release oral morphine. And why do opioid agonists work for opioid use disorder? Basically because it's a non-reinforcing way to take opioids. It addresses the cycles of intoxication and withdrawal. People on a long-acting agent do not kind of dip into withdrawal that causes them to have cravings and go to use to relieve the withdrawal. Let me tell you, what's the big deal about opioid withdrawal? It is awful. It is, people would rather, stick a needle in their arm, cooked up with who knows what that they've cooked in a spoon, rather than experience opioid withdrawal. So that's just an indicator. Like, what would it take you to do that? Well, that's how bad opioid withdrawal is. It is intolerable. It feels like you're going to die. It is not just a flu-like kind of symptoms. It's intense. So opioid agonist treatments once a day, no withdrawal, no intoxication. Bob's your uncle. And we know that we already showed you that OAT saves lives, and it's not just in BC, it's all over. Methadone saves lives. It reduces HIV and Hep C transmission, improves psychosocial functioning. People go back to work, and methadone is over. Okay, like that is 60 years old. 60 years old. We've known about that methadone is effective for opioid use disorder for 60 years. And yet access to methadone is still kind of, it's siloed. Talk about a gap between evidence and practice. Like, that's a long lag of 60 years. Okay, this is getting to the end of the slidey part of the presentation. So, what is quality care? So Health Quality Ontario has quality standards, and it has an opinion about what we should do in healthcare for opioid use disorder and opioid withdrawal. So according to Health Quality Ontario, and you can go look it up, hqo.ca or something, this quality standard applies in all healthcare services and settings everywhere that someone accesses healthcare, that a person who has opioid use disorder, that their withdrawal is treated, that they are offered effective evidence-based treatment, that they are connected to community services, and that they feel safe, that this is a safe thing to talk about. People diagnosed with having opioid use had access to opioid agonist therapy as soon as possible. If you don't have anyone on site, you should partner with someone to access. So like Health Quality Ontario says, people need access to OAT. Okay, so that's our slide. That's the sort of the didactic part. And now Tali will kind of take over and wing it and talk about.
Am I gonna?
Well, I will talk about a case. This case, we'll talk about Ellen, and we'll talk about the clinical question. So this is the time for you to participate. if anyone, I may, I feel like I should be able to look at the chat on Teams if people, you can see it? Good. So, Dr. Snatic, you can, be the moderator. Fabulous. So you've all met Ellen. Ellen is 29 years old. She comes into the ED. She hasn't been feeling well. She's had some fevers for the last week or two. And well, guess what? She has a large vegetation on her tricuspid valve. So she has infective endocarditis. She has a 10-year history of injection opioid use. And let me say that substance use disorders are a pediatric diagnosis, right? These all start in the adolescent years. So she started using, actually, to start at 19 is actually relatively late. A lot of these folks, they start 14, 15. So she's been injecting a lot of tablets. Her boyfriend gets them. And well, now she's progressed to fentanyl use by the injected route. And she also uses stimulants. You know, that's kind of a given. That's pretty common. So she uses stimulants via the inhaled route several days a week. She has no place to live and she has no ID and no health card. That's a bee in our bonnet. Did she try OAT before? Yeah, she tried methadone a little bit, you know, and it worked, but then she just was not retained in treatment. So she hasn't been on any opioid agonist treatment for 5 years. So now here's the questions for you that you're going to tell me the answers. You know, what's the optimal management of her opioid use disorder while she's in hospital for IV antibiotics? What are you going to do? This, you know, a year ago, you didn't have a substance use program team. You know, we're a baby service. So before we were there, what would you have done? What dose of opioids? Like, to give me some numbers. How many milligrams of morphine or hydromorphone would you prescribe her, would you order for her, and what route would you administer it? Oh, she needs a pick for her IV antibiotics. How are you going to address that? What about pain management? And what are you going to tell her about harm reduction? So, over to you.
I know everyone's seen this patient.
Many times. Yes.
I'm not a physician. I'd always ask, how many milligrams do we take? What format? And then I would try to talk to the pharmacist, my physician, and be like, this is about the ratio. What about the pig? I think it's establishing trust. You tell the patient, listen, I'm not here to judge you. I'm not here to lord over the fact that I'm controlling your drugs. If you're having cravings, talk to me. I'll get you something. I don't want you to leave in the stairwell at 3 a.m. to go do Lord knows what with the pig, get an embolism, bleed out. I've seen patients bleed out. I've come in the room and we have blood everywhere. It's about establishing trust and saying, listen, if you feel you're, starting to detox, talk to me. Call Bell and I will get the physician to give you whatever milligrams you need. But it's really establishing that trust and they have to feel like they're not a drudge.
Can we clone you?
Yeah.
Charlie.
Yeah, so that's, that's definitely what should do. I think the idea is people who have opioid use disorder need opioids, right? And so I think oftentimes I get calls in emerge, often like, oh, this person maybe has opioid use disorder, but we're not sure if it's safe to give them opioids because we don't want to trigger them. We don't want to, give them an overdose. We have no idea. Can you convert the street drugs, which is not entirely possible. But I think the idea is just to start at a dose that is probably higher than you would give someone who is not opioid naive and then titrate up for there. So there is no like magical number that we necessarily start with. Obviously, starting them on opioid agonist therapy would be the ideal thing, but treating their withdrawal as well as that is also very important, because what we know is that the doses that we can start, methadone or Kadian at aren't necessarily ones that will keep someone in hospital while they're like here for the first few days or while they're not feeling well. So like, it's really just kind of aggressive monitoring of the patient's sedation and their withdrawal of their pain and titrating up. So it's not just like a set it and forget it, like start them at 4 milligrams Q4 hydromorphone and And then tomorrow we'll assess them. It's really just, which is like a team effort of like nurse and physician, like assessing this person and seeing if they're comfortable enough to stay in the hospital, which is the priority instead of staying.
Patients.
That's a really good question. And I think that one, we don't have a lot of PCAs in the hospital, not all the unit. I mean, if I'm speaking broadly, hospitals, like not all units can take a PCA, or not all nurses can manage them, but it's something that's been proposed, I think, because people can control. We're not there yet. And I actually don't know of any hospitals, I don't even know in Vancouver, that do PCAs for this. So I mean, people, there's wild things that happen around, Canada, and people do kind of their programs where they'll self-administer like high dose hydromorphone in hospital. The Heart Institute and TOH are not there in that yet. But so what we can do is just kind of give people opioids, titrate up quickly, start them on opiate agonist therapy, realize that it's not enough, and ideally prevent them from using, drugs in the bathroom while they're here.
And, as far as the PCA, I mean, APS might have an opinion about that.
Yeah.
They don't know how to manage opioid use disorder, and it may not be necessary, because if they can take oral meds, they can take oral opioids in large doses, right? So and oral actually is the preferred route. It just lasts longer. If they are agreeable to take 30 milligrams of methadone, that will go a long way, right? So the treatment of opioid use disorder is opioid use disorder treatment medications, which they should be offered ASAP. And, often the oral route is sufficient.
One of the questions from the chat is, it may be helpful to provide a nomogram or order panel for inpatient in Epic. And, does this exist, or are we working
thank
towards
you.
that?
Okay, I'm excited about this. So just to repeat the question, it would be great to provide a nomogram or some guidance. Well, Epic is a great hiding place. Epic is really big, but when we went offline a few years ago, I created MMT survival skills document and opioid agonist dosing for people of for patients of unknown opioid tolerance. Those are both hidden in the physician home ATL, and it's under a weird heading, but they are there. It's under like nursing algorithms or something, which I don't know why they put it there. You sort of have to know where it is. It's an Easter egg, but those documents exist. I can, for the rounds, Carrie, for the folks who organize the rounds, I will sort of forward those, and you can distribute them.
They're also on the intranet, the TOH's intranet, which I think that people at the Heart Institute have access to. If you search substance use program on the About Us page, we have links to those documents as well.
I think, if you guys forward it to me, I'll get our IT guru
but it's not,
send out a help sheet on how to find it.
It's not like, this person uses 2 points of fentanyl and that equals this, because we can't do that. Like, we don't know. It's very variable. This drug supply is variable. The route of use makes a difference, but it does basically talk about starting OAT and then, and titrating up like opioids, other opioids, adjuncts if needed to meet pain and withdrawal, just so people, but there's no math. It's not a math problem, unfortunately. That we could just, because we wouldn't be here if it was a math problem. I think would be, we would just give you the math.
Yeah. And one other thing that I'll leave you, if there's one thing that you remember from this presentation, when you walk out the door, just one thing. For someone with opioid use disorder, you can always give them 30 milligrams of methadone. Anyone can give that. That is safe. That is a starting dose of methadone, and it will make a difference. They will feel it. Anyone can order 30 milligrams of methadone. That is not wrong.
Yeah, there's no, like, there used to be an exemption, like you need an exemption for ordering methadone. It never applied for in-hospital, but it also now is not. It doesn't apply at all. So anyone can prescribe methadone, a physician, nurse practitioner, anywhere. So it's easy. Like, it's not, although it is a dangerous medication, 30 milligrams is not a particularly dangerous amount of it. Okay.
So what happens when you prescribe that I'm going to jump in here. So what happens when you prescribe that as an inpatient for, you folks are away, it's a weekend, whatever.
Yes.
We start it in hospital. They get discharged. They don't have a primary care physician like majority of people out there. And I can tell you that I'm not comfortable, and I'm pretty certain most of my colleagues are not comfortable providing that as an outpatient.
So what's great about the addiction medicine system in Ontario, which is, there's a lot of faults, but there are many, many clinics, walk-in service, Monday through Friday, all over the province where people can continue their methadone. So as long as you have bridged it to a weekday. So if someone's, discharged on a Friday, it'd be great to give them like a daily witness dose until Monday. But if it's a Monday and you're discharging them, Tuesday, they can follow up at the clinic of their choice. So there's all these different private clinics. There's the RAM clinic, the Royal Ottawa, but like there's clinics in Barry's Bay. There's clinics like in all sorts of, if there's a town with more than 10,000 people, there's someone has set up an addiction medicine clinic. It doesn't require referrals. It's walk-in. They can just show up, and if they show up before 1 p.m. that day, they will be seen and they will be continued. So it is like, unlike the primary care system, which is all messed up, like it is actually pretty easy to get your methadone and Suboxone continued, and that shouldn't be a worry for anyone who's in Ontario. Like if you're talking about patients from Nunavut or patients, from far, and I know you guys see people from far-reaching places, that's another story, but Ontario is a really easy system.
I'm going to jump in because there was a question behind you, Dr. Static. So I wanted to make sure that we didn't forget you.
Yeah, it was less of a question. It just, in my experience, I work in palliative care as well, and so we deal with a lot of like CAD pumps and maybe not the syringe drivers that you might have been mentioning, but in like addictive behavior, I have seen a lot of people, at least patients, saying that sub-Q or IV is the only thing that works for them. And it's hard to parse out who are the people that are actually being legitimate and those who are, it's part of the drug seeking behavior. Because we do know that oral does work, but do we know, are they having like malabsorption issues, or is it that they like the quickness of onset and that's what they're seeking in that situation? So it's harder. I don't know that I would jump right to a needle driver, or sorry, syringe driver. But I think you kind of have to interview the patient and kind of get an appreciation for them first.
I'll say 2 sentences.
Yeah.
So I think there's this concept of legitimate pain versus not. Right now, I just want, it's common, right? And I mean, everything is legitimate, right? All of the symptoms, like whether there's opioid use disorder or not, it's all legitimate, right? And so anyway, some people, certainly there's a liking, right? Parenterally is a very reinforcing way to administer opioids.
I think interviewing the patient is something. I think also you have to think about, what is my goal here in terms of like, is this the way that I need to keep this patient in the hospital? What is their goal? Are they like, hey, I inject drugs, I've injected drugs for 20 years, I'm not going to stop, and I need to have some access to the injection route in order to be comfortable in hospital? I think that's something worth thinking about, and worth, maybe exploring whether that's okay in that moment, but then there are people who I would say like opioid naive people who maybe don't have insight. Maybe they don't ever inject drugs when they come in the hospital and they really like the parenteral routes. Like that's someone who I would avoid it with. And that's like, really, I have people on the list right now, both of them, so I think it's a question of like, what behavior are we going to meaningfully change? What is the goal for that person? Like, are they likely to go out and keep on injecting drugs? Is that what they've said they're going to do? Then we're not necessarily stopping anything by giving them injection like drugs parenterally in the hospital. But if it's someone who maybe doesn't have insight into the development of an opiate use disorder or any substance use disorder, like maybe we should avoid that. Does that make sense? I mean, and also the ups and I think telling people about the ups and downs of like pain and withdrawal, so that even they should be getting kind of an oral baseline no matter what. And people in the community often are on like a long acting oral med and inject drugs on top of that, because they know that helps treat their withdrawal better than kind of that, the highs and lows, Is that an answer? I don't know.
I think having a plan upfront, starting.
Yeah.
This is where we're going to start, but I'd like to eventually titrate to.
Yeah.
And if you're interested in potentially getting off things like something.
Right. I think people who've been using drugs for a long time are often very kind of honest about what their needs are and what they want. I think it's often the most challenging cases for me are people who may or may not have a substance use disorder, and they, they're like, well, I have to come to the hospital 3 times a week to get IV push Gravol because it's the only thing that works. And that's like an exploration of like what else is going on in their life, and that I wouldn't give into, let's say, if that makes any sense.
So who's the appropriate patient to refer to your program? Because we see a lot of people and, you know, this is a common problem.
We're still a really small team, so you're kind of looking at it.
Yeah.
I mean, you know, we have other positions, but you know, yeah, that's just so. I knew this would come up. There for the family physicians who are part of our team, the addiction medicine consultation team, it's a sacrifice. It's a financial sacrifice for them to come to the hospital because they can make more money in their community practices. So that's why people are not kind of beating down our door asking to join our team. And I hold the provincial government responsible for that because that's the way the fee codes work. So anyway, I just want to, that's a reality. It's a threat to our team. And so, you know, we would love to see all these patients and, you know, please, I mean, and recognize that we are, you know, we're still a little wobbly.
I think that, like, if certainly anyone using opioids, like that would be like our priority. Because I think that opioid withdrawal, like that's a time when we lose people and it's a time when we can really help people. I think alcohol is also priority. I'm fine with seeing anyone, like me personally as a nurse, because I don't get paid per patient or anything like that. But what I've been doing is kind of limiting, like, this is the help that we can provide. So I don't want to discourage it, but what's easiest is if you just page us and like ask if it would be a good referral or ask like what the timeline is for seeing someone. So doing a day of discharge referral is like not going to be great, but if someone gets admitted and then and I know how long they're going to be here, like we can usually see them. Like there haven't been many people that have been like, oh, it's impossible for me to see that patient. Like there are certain things like substances, you know, like cannabis is one, which is like huge. There's no real evidence-based pharmacological treatments. This is something where I'm referring them to psychosocial support. So it's not even necessarily something that could just be a very quick visit and kind of referring them to Access MHA or talking to them about their cannabis use. And it might be something where the physicians don't even get involved. So I don't want to discourage. I just think I want to manage expectations of like, this is why we're not seeing your patient like every single day. So page us. Tell us what the story is. If you feel like they need reassessment, you can page us again, just because there's different people on the team every day. So if you're wondering like, hey, why isn't the substance use program seeing this patient like in a day, like just let us know if they need reassessment. But I don't want to discourage referrals. So that's why I'm like, put it in and then we can talk about it. We can do it. Does that make sense?
And, you know, I mean, I'm going to be a little political here, right? If you like us, then advocate for us, right? Like ask Suzanne Medor and Cam Love, like we need more of this. No kidding, right? I mean, unfortunately, addiction medicine consultation in hospital in Ontario is far behind other provinces, Alberta and BC. I mean, those are the motherships. Like, you know, Alberta has an amazing system.
Yeah, with a pharmacist and social workers,
yeah.
stuff like that.
Well funded.
But again, I don't want to discourage anyone from consulting us because I think I haven't gotten any consults where I'm like, why are we even involved in this? There's always something that we can do, even if it might just be a quick referral if you guys don't have time to do referrals. But yeah, just managing expectations, I guess, of what we can do.
One of the questions in the chat is how closely do you work with psychiatry for patients with concurrent disorders? We often see that mental health disease goes hand in hand with some of these disorders.
Yeah. Well, we recommend psych consults a lot. I mean, I think. Oh, sorry. We recommend like psychiatry consults a lot. I mean, we work with. I mean, I think we don't necessarily work with the consult liaison service a lot, but we do. I mean, I don't know how to answer that question.
Me neither. I mean, yeah, like I guess what's evident is like we don't really have a very close sort of working relationship with CL psychiatry. I mean, most of the folks on our team, the physicians, are well versed in recognizing and kind of at least sort of assessing mental health conditions. I mean, it's so pervasive, right? So, you know, but when it comes to, oh, this person should be started on an SSRI. Oh, this person could use some, you know, Abilify. That's more tricky because if they don't have a family doctor and we start them on Prozac, then what, right? So that is a challenge.
Yeah, I think that's the biggest thing is that there's so little mental health follow-up and psychiatric support in the community. I mean, and that's not even it's like that's also a resource issue for psychiatry itself, like in terms of starting things. But that's why doing addiction medicine is great, because there is pretty good fall, like, again, walk-in service, really not possible for many other conditions.
A couple more questions. One of the questions from one of our hospitalists. I've had some patients without withdrawal used crack cocaine that declined to see the substance use program consults as inpatients. Is it still okay to ask for an inpatient referral? And also, will the patients get calls or emails for outpatient follow-ups, or is this purely an inpatient
Yeah.
a service?
We're only inpatient because there is kind of actually more support for outpatient stuff in the community. So we don't follow people. We don't have the capacity to follow people. You know, if someone is not interested in a consult with us, I think that's something where, but you feel like they should have it, that would be like a call or a page. I think I can see that in the cases of people with high opioid doses, you know, who may or may not have opioid use disorder, and we can kind of suss that out. If someone, you know, because the thing with stimulants like crack is that there aren't great pharmacological treatments. And so that would be referrals to psychosocial supports, which also everyone else can do. I mean, it's hard as that the psychosocial support piece isn't really well established outside in Ontario, especially if you don't have, you know, access to telephone, virtual care. A lot of it's through that. So that's where that makes it complicated. But Access MHA is the main referral that we do for that.
A question from Dr. Burwash. I'm going to read this verbatim. So the infective endocarditis patient is going berserk at 2 a.m. and refuses to stay. They won't stay. So do we direct them to the RAM the next workday if they will go?
Best to direct them to, I mean, to an OAT clinic, right? To OATC or Recovery Care or Sandy Hill Community Health Center for their OAT, like for opioid agonists, because that's why they're leaving, because they don't have enough opioid agonists on board. You can offer them, hey, if we give you, you know, more hydromorphone right now, would that help?
Orally. Yeah.
And
Orally.
yeah. And,
Yeah, probably. Yeah.
And, you know, like it, to me, yeah, that I can, I feel for you. I feel for the person at 2 a.m. who's handling that. To me, that's probably a sign that their opioid withdrawal is undertreated. So you can prevent that by giving that person, giving Ellen more opioids.
Right. And I think that's a good, I think that's why, so in my nursing direction that I give to people is like consistently monitoring for pain and withdrawal. Like that's an assessment. I mean, everyone nurse is supposed to hourly round for pain, but also asking about withdrawal, so that maybe is like a 7 p.m., 8 p.m. problem and not a 2 a.m. problem. So that's also, I think, an education piece to the nursing staff that hopefully, like, as the culture changes, that we'll get on, like, this is something that we really need to aggressively treat during the day and maybe avoid the 2 a.m. thing. But although I will say that, like, you know, we can't stop people from using drugs, and the drugs that we provide in the hospital are not the same as the drugs that are available a block away, you know, out on the street. So that sometimes, like, we try the best and we can't necessarily stop someone from leaving. And I think no one should own that. But if we've tried our best to meet their opioid tolerance and then they decide to leave anyway, then at least we've known that we've done what we can.
You know, and thanks. And I have one other little pearl perhaps to add to that case, because the fentanyl supply is now pervasively contaminated with benzodiazepines. So Ellen might be in benzodiazepine withdrawal. And so what we do sometimes, if that's evident, that we'll do a brief diazepam taper. So, you know, that requires a bit of assessment and judgment, but that could also be part of the picture. So, you know, it does happen that someone comes into me in the community, they're using fentanyl, you know, I get them up to adequate OAT, like more or less, but they're still going berserk. And it's like, oh, you are now chasing the benzodiazepines in the stuff that you're buying rather than the opioid component.
I mean, that's what happens when you have, I mean, the one thing about alcohol is it's regulated, you know what you're going to get. Cannabis, you know what you're going to get. Like unregulated drugs, like they change all the time. And as much we try to chase whatever the drug is, like the drugs change and that's why addiction medicine has had to change, because the drugs change so rapidly. So that's the issues with not regulating them.
Are there any other questions in the audience?
I have a few more slides just in terms of resources. So why don't I spend 2 minutes just advancing through those, and then we'll sort of do a sort of a last round of questions. Would that be okay? So, okay. All right, we've talked about, oh, do you want to speak?
Let's just go to we'll go
Yeah.
to the,
Okay, tools for practice for you folks. CEP.health has a fantastic alcohol use disorder tool. So if you haven't, I recommend that for your homework that you go to CEP.health and look at the AUD tool. It will give you lots of great information. And this is what I was, oh, and I'll speak into the microphone. And this is what I was talking about, like if you get that positive screen on the single item screening test, you can find out what to do here. Medify, I'm a totally big fan. What is that? It's a strange name. I hate the name actually, but it's mentoring education and clinical tools for addiction, primary care, hospital integration. It's a big name, but there are great tools for practice. There's a resource library, there's webinars, there's conferences. So, but the resources on there are really, they have patient resources, handouts that we print to give to patients, like what is Suboxone, what is methadone, what is naltrexone. So that's a resource that you can access. E-consult. So, this is not a rapid response, but, in the community, like if you're seeing outpatients, send me an e-consult, like go on, if you're all on the Champlain base platform, you can do that. So that's a practice support to the MDs and nurse practitioners. There's the landing we've talked a lot about Access MHA. So that's the landing page for it. Check. And so as providers, you can check that out. Like you can sort of get started. Oh, there's a little thing for healthcare professionals. You can look at that. Here is the provincial sort of resource directory. Here's the national one, Wellness Together. So you can all check those out. Yeah, ask about alcohol and OAT saves lives. That's what I would leave you with. So.
That was excellent. Thank you so much. We really appreciate you coming today and sharing the resources with us. I know we're going to need them. So we'll get the EPIC data to people once I get that sorted out. We'll figure out how to get that easily accessible on EPIC. I'll talk to Tuan about it. So thank you so much. Everybody have a good day. We'll see you at the next rounds.
Great. Thank you. Thanks. Okay. Super. Yeah. Yeah, thank you.